Hello, good evening, and welcome to EAO Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop, and in this live video session, we are going to try to answer all your questions about the do's and don'ts in implant prosthodontics. And for that, tonight I'm joined by a new expert. It's Matthias Karl from Germany. Matthias, good evening.
Good evening, Gerrit. Thank you very much for the invitation.
Glad to have you with us tonight. For people who haven't Googled you yet, you are a prosthodontist, which you taught me is the architect of the oral cavity. You are a professor and department head at the Saarland University Medical Center in Germany. You've published over 160 papers, mainly focused on the biomechanics of prosthodontics. And you told me earlier that tonight we are going to dive into the dark side of implantology, because we're going to kick off with a failure festival to better understand the do's and don'ts of prosthodontics. So I'm really looking forward to that.
Well, Gerrit, to be frank with you, I don't know if it's really an honor that you invite me for a failure festival. Actually, everybody wants to show good cases, but unfortunately, it's true. The patients we are seeing here at the dental school on more or less on a daily basis, and this is unfortunately the focus of our clinical work. These patients have been treated by different clinicians. They sometimes received very complex treatment, mostly implant supported. Something went wrong, and we are supposed to fix those problems. It's a broad range of patients that we are seeing with different medical backgrounds also. Finances, interestingly, are not really hindering patients from seeking implant treatment, but there still seem to be several misconceptions from a prosthodontist perspective that simply do not match with what we are used to in treatment planning, what we are used to regarding technology, regarding materials, etc. And this is what I would like to show you.
Yeah, perfect. We're going to go through these different themes, kicking off with just exploring some of the failures that you have seen to better understand how we can prevent those type of failures. And as always, I call out to everyone who's joining us live here on Monday night to please use the fact that we are live by submitting your questions, any questions you might have during the next hour, through the live chat. And also, by tradition, I've kicked off by inviting you to let me know who you are and where you're joining us from. And a regular guest on the show, Victor Palari, is joining us from Moldova. Victor, good evening. Glad to have you back. If you are now watching us live, make sure you make yourself known in the live chat so we actually kind of get connected around the world. If you're watching this in recording, of course, you can still in the comments let us know who you are and submit your questions, and we might get back to those later. Well, Matthias, let's get started. As promised, let's better understand the type of failures that you see in the clinic, so we can then use that as a basis to better understand the do's and don'ts in implant prosthodontics. In the meantime, quick shout out to Turker Ornikul, also joining us from Istanbul. Good evening, Turker. Glad to have you with us as well. And with that, let's get this party started. There we see the first radiograph on screen. Matthias, please talk us through what do we see and what went wrong?
Well, in my opinion, this is a classic situation, a classic Monday morning situation. And we all know that there are different treatment concepts out there for instance, restoring an edentulous mandible. And yes, there are these beautiful mini implants. They are available as temporary solutions or in cases with severe bone loss, as in my opinion, the last option to restore an edentulous case and to stabilize mandibular denture. But in this instance, in this patient, these mini implants have been, I would say, distributed across the mandible in the randomized way, and I don't know how you want to restore those implants. When you have to take them out in order to go for a proper treatment plan, this leaves a big disaster for the patient. These are all big holes that will not fill in with bone. It's next to impossible to come to a proper restoration, a working restoration for that patient in the mandible.
Exactly. So you say this is a case of where the initial planning, the whole first design already went off on the wrong foot.
I mean, I don't know why people are doing stuff like this. There are different concepts of using one implant in the midline, of using 2 implants in the canine region, of using 4 implants in the mandible, of doing an all-on-4 restoration, or doing 6 implants of all fixed restorations. But why do you place 6 mini implants in the mandible in order to restore it? They do not have a common path of draw, so it's impossible to properly use those and come up with reasonable long-term results for that patient. It's, in my opinion, poor treatment planning or not being aware of the standard concepts, which are well known in the community.
Yeah, and in the end, these patients come to your hospital with a problem, and this is what you find.
Exactly. That's unfortunately our daily business. And then you have to tell these patients that everything has to come out and you have to start from you and you have to do what today you would like to avoid. These are major bone augmentations before you can restore those patients again.
So it all starts with proper planning. Let's see a few more.
Yeah, this one is also a classic situation where, in this case, talking about the maxilla, the mandible also has problems, of course, but the maxilla was the reason why the patient saw us. Sometimes I really do not know why we write all these funny publications. There is a well-known series of clinical data of review articles out of the University of Bern, clearly showing that tooth implant supported combination restorations do not really work properly. And as you may imagine, this patient does have issues with this bone loss, PeriImplantitis, but also periodontitis. And how does this patient end up now? The oral surgeon working in my department took out the whole restoration. And of course, this is a disaster for the patient because you leave the patient with huge defects, which are difficult to rebuild. And as you can imagine, and as you can see from this image, the patients also paid a considerable amount of money to get such a restoration in the first place. So it's always sad when you hear these discussions with the patients, what have I done wrong? Why do I have these problems? I'm not saying that these are bad dentists or bad colleagues, don't get me wrong. We also have these cases where we do more or less everything wrong or where everything goes down the drain. But there are some substantial failures that we obviously make, and we master crazy techniques like bone augmentations, guided bone regeneration. We try to treat PeriImplantitis, etc. So I do not understand why we make big mistakes and big failures during these very simple pre-operative planning phases.
And just to understand really clear what went wrong here, it's the combination of the implant or the tooth supported and the implant right next to it. That's where things go wrong.
It's never combine teeth and implants in a fixed restoration. We always look for either tooth supported restorations or implant supported restorations. When we're talking about fixed restoration, it's not a problem to combine teeth and implants under a removable restoration. This is just fine. Also, when you look at the implant size for that molar in the upper right, it's a very short implant placed in quite weak bone because you're far back in the posterior. Also, you have a very long span bridge. So this was bound for failure, actually, in my opinion.
Yeah, it's basic planning phase failures. That's why you're showing this to us.
Yes.
Here's another one. Help us see what we need to see here.
Well, if I had to guess what this colleague did on the weekend before he saw that patient, I would claim that this guy attended a continuing education course on all-on-4 restorations, where straight and angulated implants are being used for increasing the support of hybrid restorations. We also use the all-on-4 concept, and I think the all-on-4 really is a game changer in implant dentistry because it allows the restoration of cases that are highly resorbed, where bone augmentation can be avoided in many instances, but this is for terminal dentitions. You have to take out the teeth. You cannot keep the teeth, and you need a proper concept for this. When you look at the restoration like this, it's obvious with these long span bridges with, again, support by implants and support by teeth, that there has to be a failure. Also, the implants, you cannot really tell from this radiograph because it's two-dimensional. But I would bet that at least one implant is not inserted in bone, but inserted in a tooth next to it.
Exactly, there on the right side of the image. Huh?
On this one may be it, but also this one may be it too. Surprisingly, those teeth have root canal treatments because it hurts, of course, for the patient when you drill into a vital tooth, which then becomes necrotic most likely and gets a root canal treatment. But this I don't know in this case. I don't know about the history. This is just how the patients show up. And of course, there is severe inflammation, etc. And you have to take out basically everything. And when you count, this patient has received 7 implants, paid a considerable amount of money, and now you have to remove more or less everything. And you have to redo it. And
even the remaining teeth then, probably, right?
Everything has to come out, and you have to start from scratch. You have to rebuild it. So the implants in this case did not solve a problem. They created a problem. And this is, to me, it's every time sad to see these implants are really great. I love them. It's supplementing our treatment alternatives or our treatment options in prosthodontics, but you have to use them in the right way. Exactly.
You have more? Yeah.
Unfortunately, I have more.
What happens here?
This is a case that really made me angry. We are talking a lot about PeriImplantitis and a lot about treatment concepts for PeriImplantitis, and just among the two of us, we do not really know how to treat PeriImplantitis, and in my opinion, we do not even understand properly why some patients suffer from PeriImplantitis and others do not. That's my personal opinion.
Well, and I think, to be honest, that is also rooted in science, because we've had just asks on the topic of PeriImplantitis where we can only talk about risk factors, right? We start to understand risk factors, but how it exactly works is still a bit of, well, under research, we say. Yeah.
In this case, to me, the risk factor is quite clear. The risk factor was the restoring dentist. I mean, this is not a bridge. These are not teeth that were put on these 3 poor one-piece implants. This is basically a fence that was put there, and it's impossible for the patient to clean those implants. So yeah, it's kind of restoration with built-in chance for PeriImplantitis. So we do not have to talk about genetic factors here. We do not have to talk about smoking. We do not have to talk about a certain microbiota. Just get proper teeth for this patient, and then there is a much greater chance of avoiding PeriImplantitis. When you see things like that, we teach to our students what a tooth should look like, or restoration should look like, from day 1 of their undergraduate studies. And it's sometimes simply sad to see cases like this where really fundamentals of prosthodontics are obviously overlooked for different reasons.
Yeah, and in this case, the fundamental principle of cleanability. Do you design something that can actually be maintained by the patient?
Yes, exactly. Another one, this is a highlight in my career.
What do we see here, Matthias? Talk us through.
Well, it's, I would say it's the Golden Gate Bridge of implant prosthodontics, where these 2 beautiful anchors have been used to stabilize, again, implant and tooth-supported restoration. I really have to meet the dental technician one day, because I do admire this guy. He obviously managed to properly seat such a huge and complicated restoration. This is an older case. It's beyond or before CAD/CAM technology was really available. So I don't know how he managed to properly seat the restoration on these foundations, but he did. Somehow he did. And of course, the same problem again, and the patient cannot really clean this, and he cannot really use this from a biomechanical point of view. It's a disaster, and the way these implants are oriented and the way the restoration is basically constructed. So, and of course, this has to come out. How do you want to solve this problem?
Because we see on the left side of the image a huge bone loss. The black gap is
all this is gone. All this is gone. We are close to the nerve already in that area, but this area is completely air or soft tissue. It's no bone anymore.
And just to really be clear on understanding, you're showing this tonight to show that if you don't plan properly on the prosthodontic sides, or even already on the implant side, but on the combination of both, you are setting yourself up for failure in the long term, correct?
Well, the way I see it, in order to have success in all what we are doing, this is never a one-man show, and it's always multifactorial. You have to see the patient when you do a treatment plan, and this is why I said the prosthodontist is the architect of the oral cavity. You have to see the patient. What are the capabilities of the patient? Is the patient able to keep fixed restoration clean, or is he not able to keep that clean? What is the local situation? Do I need implants for strategic support of something? Would it be better not to do an implant? What is the medical condition? Then, of course, you have to, in my opinion, we are too much focusing on these technical aspects. How do I place that implant? How do I do the bone augmentation? How do I do the soft tissue management in those cases? You also have to look at the materials, at the quality of the materials that you have and that you are loading. It's a considerable amount of loading what you put onto these very small structures. And then in the end, it's maintenance. We have seen it during the pandemic. Of course, we do have a recall scheme at our dental school here. And with the pandemic, the patients were not coming in. Older patients, of course, they were afraid of seeing a dentist during the pandemic. And you see how things worsen in a very short period of time that have, before the pandemic, been able to be maintained for a quite long period of time. So all these factors come into play for long time success in prosthodontics, I would say, not just in implant dentistry. But this is known, this is perfectly known, and also these colleagues know it.
Yeah, exactly. But it's good to be confronted with, although we all know how it's done, and although it's dental school basics, what happens if you don't adhere to those rules? Show us a few more of these cases in the Failure Festival.
Well, this one is classic to me also. As a prosthodontist, for me, the implant has to be very simple and straightforward. I'm not used to advanced surgical techniques. I'm always happy and when the implant is in and I survived and the patient survived. So I'm always admiring those guys going into the sinus and doing all sorts of fancy stuff. But sometimes when I see radiographs like this one, I wonder if it's possible to compensate for a lack of surgical skill. I do understand that there has potentially been an open sinus after extracting that molar back here in the left maxilla. And then you can already see that beautiful snowball that was placed in the sinus. But when you already have done this, and I mean, this is like a boxing fight for the patient. In most instances, you get gray and you get blue and you get green and you get yellow and whatsoever. When you already do the sinus lift, then please place an implant in that area and place maybe a second implant in this area. And then you can do a just implant-supported restoration. Obviously, the surgeon or whoever and did the sinus lift did have no idea about the final treatment plan, because I would guess that the sinus lift was not really needed, because this implant is at the border between the sinus lift and the native bone that was present in that area. So I think either you go for the sinus lift, then place a proper amount of implants, or leave the sinus alone and place the implant in the native bone. Later on, we will maybe also talk about passivity of fit of implant-supported restorations, how important that is for technical longevity of our restoration, not so much for biology, but for technical longevity. And when you see cases like this, where the crown that fits on an implant more or less fits on an implant, and it creates a gap of this size, so you can really see it in such a radiograph, which is not super precise. Also up here, you see a little gap. Then this should come out. On the one side, you see these fancy procedures, surgical procedures that are being done, and on the other side, you see, let's say, compromised prosthodontics. And this is always said for me, because for prosthodontics or prosthodontic intervention, the patient does not have to suffer, as is the case in surgeries.
And when you say this has to come out, you're referring to the full restoration or just the implant?
No, the restoration. Exactly. The implant stays. Just redo the impression and get a new crown. It should not be an issue in today's world with all the CAD/CAM technology that we have available.
Exactly. I see you have one more for us. What do we see here?
I do have many more. Unfortunately, but again, it's not bashing the colleagues. We of course also have cases, nightmare cases, and let's be honest, everybody has these nightmare cases where things simply go wrong, where you have made a wrong judgment. But I always want to make sure that these cases are not the majority of patients I'm treating. It should be in a very few percentage or a very small percentage of patients.
And well, let's be honest, in the context of tonight, if we talk about do's and don'ts, let's start with a proper understanding of the things that actually go wrong in practice, and then build up from that when understanding that. What went wrong in this patient that we see here?
This patient came in and asked for a new bridge on these single piece implants. You see the bone loss around those implants, and I refused treatment for this patient. When you look on this tooth with that periapical radiolucency in the lower right, this patient requires a proper treatment plan for the complete mandible. The X-ray has some distortion, but I can tell you from a clinical perspective, there is no plane of occlusion that was properly established during the first treatment. So there are many, many more problems than what you can see here on that X-ray. And this patient would require a complete restoration, maybe redoing some of the pros work in the maxilla. There's a removable restoration on telescopic crowns, but you really have to reestablish a plane of occlusion, and this is not possible in this case with an easy measure of just redoing that bridge. Again, these are single-piece implants, not two-piece implants. Very difficult to retreat those. Sometimes these are just small companies that may have already disappeared from the market, so you do not get parts and pieces back. And this is what I'm really advocating. We are placing implants in comparably young patients, and those patients, they will get old. They will get 80, they will get 90 years of age. We have those patients. The oldest patient I've treated with dental implants was a lady. She was beyond 90, and she received the first 2 mandibular implants. So these people are really getting old, and we all hope that we are all getting old. But that means, from a technical perspective, that we will have to redo and redo and redo those restorations again. So please use proper parts and pieces, document what you have placed in that patient, and make sure that these parts and pieces, at least the pros parts, will be available for re-restorations in 10, 15, 20 years from now. That's a very, very important part.
It's a very important message here tonight. Exactly. Document what you put in. What happened here?
Everything happened here. Again,
talk me through.
No plane of occlusion, no plane of occlusion. That's the first thing a prosthodontist normally should look for. 8 implants. Again, they have been randomly distributed in 2 jaws. Actually, in this case, with 8 implants, you can completely restore that case with 2 beautiful all-on-4 restorations, both in the maxilla and in the mandible, and the patient would be happy. Now, this patient is a big mess. It's a big disaster. Maybe these 2 teeth, the lower right canine and the lower first right premolar, may have a chance of surviving that intervention. The rest of those implants and teeth has to come out. Who explains
and again,
this?
Huge bone loss.
Yeah, of course. There is a little bit of. I'll show you a clinical picture so you can kind of associate those radiographs in a minute with what we would see clinically in the patient's mouth. Everything has to come out here, and you are the one now explaining to the patient why this was crap and why you have to redo it, and why the situation is worse now compared to the situation the patient was in several years from now when he started with the first treatment. Okay. The last one. I promise you the last one, because
and then we're going to build up into the do's. Yes.
Yeah. And we all will have a big depression after this evening. Another case. This lady has several medical issues, and she got these implants, and she also told me on how much she paid for these implants. They're all over the place. These are, again,
I'm already counting 12, right?
Yeah. You can do a lot with 12 implants, and also you can do a lot with the honorarium you derive from placing these implants. But this is what she looks like clinically. And yes, you can fill a complete textbook with this patient, starting with the medical history, and then also starting with prosthetic design, starting with where do I place the implant, where is it correct to place the implant, where is not correct to place the implant. And this is certainly not PeriImplantitis that came to those implants for, I don't know, microbiome or whatsoever reasons. This is just the wrong implant position. This is terrible for that patient. This is work still in progress.
How are you so certain, Matthias, that the soft tissue has not resorbed? This was there from design, you see, because there's no inflammation.
It all depends on the implant position, where you place them buccolingually, in which area, and where do you start from. I mean, when you see this clinical situation that you already have some recession around those two, around this canine here, the implant is clearly too close to that canine. Same situation on the opposite side. It's not so easy to treat the anterior mandible, but also when you look at the restoration design, I mean, the soft tissue used to be up here. I'm quite sure it used to be up here. How do you want to clean such a restoration? It's impossible for that patient, even though it's in the anterior region where the patient should be able to easily clean those restorations. So it's really the fundamentals. It's really the fundamentals that are oftentimes, unfortunately, overlooked. You know, sometimes I think it's just the wrong place I'm doing dentistry in, that I have to see all these cases from the dark side of implant dentistry.
Exactly. Well, thank you for kicking us off here tonight. Let me quickly make a shout out to our viewers joining us live. I found a few who checked in. We have Gerrit Geerlings joining us from Achelen in the Netherlands. Aeon Aeon Fleetwood from west of Ireland. We have Eleni, good evening, from Cyprus. Peter van Elsas at Bloemendaal, the Netherlands. Melania, good evening. Eva Betnarek from Zurich. Wenzel Payet joining us from Austria. Lysenko Alex from Moldova also. And Christopher Appelquist from Sweden. Good evening to you all. Now it's up to you to make the most of this live EAO Just Ask. If you have a question for Matthias, please submit it in the live chat. In the meantime, we'll talk a little bit further, Matthias, about all these, well, what shall we learn from this? How do we transform this failure festival into not only the don'ts of prosthodontics, but also the do's of prosthodontics? What shall we learn?
Well, in my opinion, the first question that you always have to ask yourself, and what you have to ask the patient, is why? Why? Why have you lost your teeth? What was the reason for that? And I can show you another case, just to show also to the audience that we are not the superheroes every time. But
this is a case from your own library, I understand.
Yes.
So
unfortunately, yes.
This is your own horror case. Talk us through.
This is a lady. She was born in 1982. 1982. She first presented to the dental school here in Hamburg in 2014 with that radiograph you can see here on the upper left. I apologize for the quality. It's a scan from a real radiograph, from a real X-ray. Again, we are talking about a beautiful young lady who takes care of herself. She's really a beautiful lady. She's highly educated. And she has had all the preventive measures that are available to our patients from day zero. And it's a miracle why this lady already had tooth loss, why she has so many root canal treatments. An implant has already been placed. And at that time, it was decided to take out these teeth here in the upper right and to replace those, of course, with implants. What else do you want to do? Implants. It's a young, beautiful lady, so do implants as many as you can. This was planned in 2014. It went back a little bit, back and forth. Some prosthetic work was also done. Then the implants were placed in 2015. And hold on. Then in 2016, second stage surgery for these implants. And then again in 2016, planning for an implant in the lower right. Then in 2016, these 3 implants in the upper maxilla failed.
What happened?
Bone loss. Bone loss.
Okay.
And as you can see, there is no more bone underneath the sinus here. Then this lady underwent major bone grafting from the hip. This was also done in 2016. You see these fixation screws.
Yeah.
And in the beginning of 2017, this is when I digged in, because I moved to Saarland. Then you can see the resorption around those screws. So the bone graft will never survive to 100%. It'll just survive to such an extent that you hopefully can place those implants. And this is the time when I was asked, hey, where do we place implants? And I said, I don't care where you place those implants. Just place an implant wherever it's possible. So I do get some support for a removable restoration. Then people were shouting at me, how can you dare doing a removable restoration on a lady that is now 35 years of age and looks as beautiful as this patient does? And I said,
yes.
What else?
How could you, Matthias? Help us understand your consideration there.
Well, Gerrit, it's quite simple. When you look at the initial radiograph of that patient,
From 3 years earlier, you mean, the 2014 one?
Yes. Yeah. Why does a young lady with a non-contributory medical history, with no drug career, who is really healthy, we checked everything on this patient. Why does she experience dental caries, tooth fillings, afterwards pulpitis, endo treatment, periapical radiolucency, tooth extraction, bone loss, bone augmentation does not work, implant placement, bone loss around those implants lost. Now you have to rebuild them. Something is wrong with that patient.
Something is wrong. Peter van Elsass is writing live on the live chat. Anything in the medical history that we should know? You just said in a by sentence, no significant
nothing.
use there.
We really checked her after the first disaster with those implants. There was really nothing. We still do not know. We honestly do not know what happened. So I said, it's going to be removable. Of course, the patient loved me. And this is how she ended up with. It's very simple, a very simple removable restoration. I tried to touch as few teeth as possible and just to get it done. Just to get it done. So this is the maxillary restoration.
And this is an important principle, I think. You said I tried to touch as few teeth as possible. Yes. Why? Just to make sure there's no interaction there or potential interaction.
Well, Gerrit, it's quite easy. You lead a happy life if you are able to stay away from the dentist.
True.
If you don't need us, then you have the best life ever. So this is the mandibular situation where we just used one implant with a very simple locator type attachment to kind of give some vertical support for this removable restoration. And this is now the situation the patient is okay with. Now she's a mom with 2 kids. Now she's turning 40 this year. So dentistry is no longer in the focus of her life. Is this a disaster? Oh yes, believe me, it's the biggest disaster. And I always, get goosebumps before I see her. And whenever she is scheduled, this is a nightmare case. And I do feel sorry for this patient, because what we often do not see is all the stress and all the loss of quality in life those patients go through over a period of time during treatment. Normally in presentations, you only see this was the starting point and this was the end point, and wow, it looks perfect. But these many surgeries these patients sometimes undergo, that's really a tough situation. So in my opinion, the first key factor for success is to reconsider our treatment concepts. Is it really necessary to place a dental implant in every patient? I love them. Again, we do them. They are good. They have a perfect long-term perspective, but there are still patients who are better off without dental implants. And this lady would have been such a patient.
And just to reflect one last time on this specific case, was there anywhere in that, because this all looked like you try one thing first, that fails, you try the next thing, you try the next thing. Do you feel in hindsight there was any moment earlier that you should have made that decision, or is this only hindsight that we now deal with?
Well, for me, it's easy to answer that question, because I came in and I saw her first in 2017, so I already saw those X-rays and saw all the work that has been done previously. But the problem was that, from our perspective, being dentists and having a beautiful tooth is the best thing you can have in life for us. So we do not treatment plan young people for removable restorations. This is a no-go for us in our minds. And
in general,
in general, how can you do a removable? It's impossible. But there are, in fact, cases where you exactly need a removable. And in the older population, I do have a number of patients coming in and say, I rather would like to have a removable restoration. So because of the ease of cleaning, I sometimes do have difficulties in cleaning fixed restorations or cleaning my teeth. So I would like to have a removable, but we think this is a second best solution for many patients. There are more technical complications in removable restorations, absolutely agree. But there are situations where the removable is the way to go, and less implants sometimes is also the way to go.
Exactly. So here we hear a first do of the night, right? From the prosthodontist perspective, maybe also consider removable prosthodontics even in younger patients. I see that our audience is waking up on the live chat, and I feel that some of them are just pasting a few of the themes that we promised them in the description of this video. Victor Pallery is writing, can we have the same accuracy of the original versus non-original abutments in dental implant restoration? And I think that fits straight into a theme that you would also like to touch on with us. What can you say about that?
We have done some research in that area, and the quality of the components that are provided by industry is quite important for us. What you see here is a fractured implant, which has been used for supporting a 3-unit fixed dental prosthesis. Now, of course, implant failure is rare. Luckily, it's a rare event, but it does happen. I can show you several cases from my department where implants actually have failed. We have adopted a very arrogant attitude, in my opinion, because we know that implants last, they function very well. Industry has to test those implants extensively. So we try to save money, of course, and we try to use like clone abutments on some type of implants. And this is, in my opinion, a very critical factor. And this problem also especially started with the advent of CAD/CAM technology. What happens with an abutment that is placed on top of an implant is what you can see here in an experimental setup that we used several years ago. You can see an implant that is embedded in a holder, and there is a simple abutment placed on top of this. And this is a loading actuator. And we used this setup for measuring relative movement between the implant and the abutment during the loading situation, because this is exactly what is happening clinically. And this is believed to cause wear and to also cause fatigue and potentially cause these fractures of the abutments or of the retaining screws or even of the dental implants. And what we have done in a study, we have published that in 2018 for a renowned dental implant system. On the left-hand side, you can see that specific implant and original abutment that goes on top of that implant with its prosthetic screw. So this is kind of the gold standard for this implant. And all the other ones look quite similar. But when you have a closer look into these images, you can see that the gap sizes between the different parts and pieces are in some areas a little bit bigger, in some areas a little bit smaller. The screws are a little bit longer, a little bit shorter. And we try to compare these original abutments versus these copycats or clone abutments. And what we found is that when you use clone abutments, doesn't matter from which manufacturer, you have a greater chance of introducing a higher level of variation for these micro movement phenomena.
Wow, this is an impressive graph. Talk me through it. What do we see?
You see a spider graph from this study where we use different measurements, numerical measurements from the original component manufacturer. What is, for instance, the angle of the implant abutment interface? What's the height in different parts of that abutment? What's the micro movement? What is the amount of preload, etc., etc.? What's the bacterial penetration with the original part and with the clone part? And we use the original part as a reference, and the clone parts are simply introducing a lot more variation compared to the original part. I'm not saying that these copy parts are showing a poor performance per se, but the risk that you run as a clinician is incredibly increased when you use non-original parts. It is important to understand, in my opinion, that an implant does not work without an abutment, and the abutment does not work without the screw. And this is the reason why all the implant manufacturers, it doesn't matter which color they have in their corporate identity, it simply doesn't matter. They have to test it as a system. The implant plus the abutment plus the screw. And this is what is certified on NCE marked, for instance, in Europe. And this is what we should obey to. Also, from that restoration perspective, it's a nightmare when you know, hey, this is a non-original abutment that was provided by some sort of laboratory, and I need a new screw now. Then you have to dial different telephone numbers, and you have to hope that you will get the right screw. When you use the original equipment, then you do not have this problem.
Exactly. And this also goes back to the point you earlier made. If you use different components, really document well what you use and where you got it from. Is this then also the answer to Alan Busso's question that says, do you see any difference between low cost and premium implant companies? I guess this graph is showing that, or is it not as, is it a shortcut when I say this is also premium and low cost?
It's, no, I would not support that. It's do not combine different manufacturers. This is the
and then the price point doesn't matter per se.
Do not place an implant from manufacturer A and put an abutment from manufacturer B. I do not see such a huge difference between the value segment and the premium segment anymore. In fact, I would say that the smaller implant companies sometimes do have very nice parts, and they are driving innovation. They are more flexible in adopting new ideas and bringing those to the market as compared to the well-known and bigger brands.
Exactly. But the key message is don't mix the components. Exactly. Clear. I'm writing down another do in the do's and don'ts in prosthodontics. Another question from Alan Busso. Let me see if I can pull it up on screen as well. He's asking you about the passivity of fit. What is the passivity of fit of implant-supported restorations? Again, I think he also copied that from our description, so he would love to know more. What do we need to know about the variables, the clinical assessment, and bone adaptation? Can you share that with us? Let's see. I think you've done a lot of your work on that. At the moment, we're not seeing your screen yet, but I see you're pulling that up. There we go.
Perfect.
Wow.
Oh. What you see here is 2 implants that are embedded in photoelastic resin. And just by adding a 3-unit fixed restoration on top of these 2 implants, the stress situation around those implants changes dramatically without any dynamic loading, without any masticatory load going on top of this. The reason for these static loads, for this misfit between the implants and the restoration, is that we are idiots, basically. We have no idea, and we have no means and no capability to transfer the clinical situation from our patient one-to-one to a laboratory situation. No matter if we use conventional techniques or if we're using CAD/CAM techniques. As you have already mentioned, I've done some work in that area, and we never managed to fabricate a restoration from any material that would just fit perfectly in such a sense that misfit loads do not occur. It has long been believed that these misfit loads do cause peri-implant bone loss, would at least be a cofactor in peri-implant bone loss. And we were actually the first ones to show that these misfit stresses, if they are superimposed by dynamic loading during masticatory function, may induce bone adaptation. So even those implants, the supporting implants are also integrated. They still may move in bone, may move in bone, change their position. We're talking about a few micrometers in order to reduce the amount of misfit stress. And this really happens. There is a newer study by the group from Schwarz who also showed this in an animal model, but we showed in a patient a couple of years ago. So from a biologic perspective, I would say that passivity of fit is not necessarily needed, but from a technical point of view, for the stability of screw joints and for avoiding microcracks in veneering ceramics, for instance, it's a crucial point. It's absolutely a crucial point. So you should strive for very precise components and very precise procedures, especially when you do an impression. I hope that no technicians are listening, but the honest answer is that 50% of the inaccuracies inherent in such a restoration are caused by the errors we are making during impression taking.
Well, there's a question from Laura on that in a moment, but I just want to make sure we get this point really clear. So your research has shown that due to the passive stress, the implants might still move. When we transfer that into the planning phase, how do we use this knowledge clinically?
You are less afraid of the exact implant positions, actually. You are not looking for perfect parallelism of these implants. When you are doing a fixed restoration on top, you're not too much concerned. It's more the prosthodontic technique of doing an impression and how you fabricate your restoration. Do you do a verification cheek, for instance, to ensure that you get a maximum of precision?
Exactly. And you mentioned very carefully when you do a fixed restoration, you just also made the case to every now and then, perhaps a little sooner, consider a removable restoration. How does this aspect change when we move into the removable restorations?
Well, in removable restorations, there are different types of attachments that we can use for retaining a restoration or for retaining a prosthesis. And what is in widespread use right now are locator type attachments or ball anchors. I think in the past years, the locator or locator type attachments are in the majority of cases being used for retaining these prostheses. And one of the biggest issues we see with these locator type attachments is wear at the retentive interface between the matrix and the matrix system. So the patients come in and they complain that the prosthesis in the beginning was quite stable and there was a lot of retention force. But due to non-parallelism of supporting implants, if one implant is absolutely straight and the other one is tilted, you never hear one click if that restoration goes on top. You hear click here and a click here. And this indicates that you do not have a common path of draw for these two implants. And this then leads, in combination with the transfer inaccuracies that we see in prosthodontics in general, then leads to greater wear of these restorations. The alternatives we have as a retention mechanism for these removable restorations are quite costly. As Germans, we use telescopic crowns quite a lot. Individually fabricated telescopic crowns, they are not available everywhere. And again, they are very, very costly. We do not like bars, at least here in Hamburg, we do not do any bars anymore. They are expensive, very expensive. And for the patients we are seeing here, they are next to impossible to be cleaned properly by those patients.
Let's dive into a few more of these audience questions. I have a nice stack for you, but I actually want to dive right into the last question from Sylvain Montanet. He says, we're talking about passivity of fit, and he says, how can we test that passivity of a bridge? Is that needed? And if we want that, how can we do that?
Is it needed? Yes, it would be needed. Definitely would be needed. Is it possible? No. Clearly, no.
It's simply not possible.
It's simply not possible. There has been the so-called single screw test or Sheffield test. So when you have a bridge that is supported by several implants, you just tighten one retaining screw and you have a look on whether or not the bridge lifts up on another implant. We have shown in the past, as part of that passive fit project, that in a finite element analysis, in a computer simulation, that neither the horizontal discrepancies between implant position and restoration, nor the vertical discrepancies between implant and restoration are really critical. What is critical are deviations in the angle. So when your restoration is not too long or too short, or in the vertical displaced, but when there is an angular deviation there, this is critical, because these angular deviations lead to very small gap sizes in the range of 5 microns, 6 microns, and you will by no means be able to detect those deviations, which are equally harmful compared to a horizontal discrepancy of, let's say, 30, 40 microns, where you do have a chance to detect them. So I would guess it's impossible on a daily clinical basis to detect these deviations and to detect a non-passively fitting restoration. We are not talking about those restorations that are grossly misfitting as the ones I've shown you.
It's the small ones.
Yes.
Yeah. So what do you say? What do we do with this? Is this bad luck, fact of life? We can't do any better, or is there a do that we can distract from here?
If we apply proper technology, if we follow the workflows from the manufacturers, if we use good quality components, then we reach those long-term perspective, and we reach those long-term performances that have been published over and over again for fixed restorations, which are reasonably good in my opinion. So I don't think that it is necessary to achieve a passive fit, a perfectly passive fit. So the body seems to accommodate some misfit. This seems to be okay, but we should not overstress that system.
Exactly. Very clear. Thank you. Let's throw a few more of these questions at you. Dr. Anand Zahalka sends the same question twice. What is the impact of the surgical trauma on the aesthetic failures? Would you like to comment on that? And it might be slightly off topic, but let's see what you can do with that.
Well, as I already mentioned, I'm not the super surgeon. I'm happy if the implant goes in, and I sometimes admire those guys who place implants with a high level of primary stability, where especially in conical implants, they do a lot of compression in the cortical bone. And then they load those implants immediately. And I'm always reluctant of doing that. I'm a coward. I'm almost always doing a staged approach, and I try not to overstress the bone. But this seems to be a current trend in dentistry. So it's like going to McDonald's or Burger King. You drive through and you start with no implants, and then you have the implant and you have the restoration that already is on top, and everything is stable and everything is fixed. You do need a very stable implant in order to load it prior to the biology happening for osseointegration. So what often happens with many designs is that you simply derive primary stability from the cortical part of bone. And this happens, for instance, by undersizing of the drill hole. And you compress the cortical layer of bone, which then leads to bone resorption. And yes, this is where my beautiful crown margin is normally located. And if the bone or the soft tissue disappears around that, then you can see this margin, and this makes me unhappy.
Exactly, and we might end up with the pictures like we saw earlier in the broadcast tonight with the exposed implants or more. As viewers might notice, I'll just go from the top now in chronological order. So Dr. Mason writes, what do you think about using only one implant for an edentulous mandible? We talked about all-on-4 before. What about all-on-1?
All-on-one. Well, this concept of all-on-one, of doing one single implant in the midline of the mandible, has been around for quite a while, and there are several publications showing that these single implants in fact do work, and at least for some time they lead to an improvement in the quality of life of those patients. I personally do not have experience in placing one implant because I honestly do not see the benefit. When I do an implant surgery, the patient already has to pay for all the basic equipment, for the setting up the surgical room, and for the hose that you need for the surgical motor, etc. So the difference between placing financial difference between placing one implant or placing two implants is a couple of hundreds of euros in our setting here in Germany. So it's not doubling the fee when you place two implants, but this is the tried and true. So I do not see a financial benefit, and this is normally the driving train for these mandibular single implant prostheses. I do not see this, at least in our setting here. So I tend to place two implants.
Exactly. You say better safe than sorry, and as the other saying goes, don't be penny wise, pound foolish, right? Because you might take more risks with that. Next question on the top right now is, it moved because Alfonso Gil is making a shout out. Very interesting discussion. Thank you, Alfonso. Here is Laura Landau's question. She says, following the generation of the emergence profile, how to make an impression? Can you comment for us on that?
How to make that impression? Yes. We meet again for this topic for another hour, and there are different.
Exactly. It's slightly off topic, right? Yeah. Can you understand the challenge that Laura is referring to?
Yes, here? Yes. When you have created a soft tissue profile during the provisional phase of the restoration, you have modeled the soft tissue so that you recreate papilla. And there are several articles, for instance, by Julia Wittneben, who has shown that with a dynamic pressure technique, it's possible to kind of model the soft tissue in that area. If you do a regular impression with a round transfer post from any manufacturer for this implant system, then the soft tissue collapses and you are not able to properly transfer the emergence profile that you have been working on for hours and for weeks and for months for the patient to come in again and again. You're not able to transfer those to a laboratory situation. What we have set up, but I have to admit that this is, it's part playing and it's part finding the right parts and pieces and components. But we have now set up a set of components where you have a specific cup, where you can have a proper model analog for the implant system. And we try to transfer, as has been described in the literature, to transfer this emergence profile, and we modify and individualize the transfer component that we are then using for the impression. Same story for the digital workflow. We also modify our scan bodies to reflect and support that soft tissue area.
Exactly. So that is a first hint. And further than that, we might do a next Just Ask on this as well. Let's see if we can tackle as many questions as we still can in the remaining few minutes. Next one up is Lysenko Alex, or Alex Lysenko probably. You talked earlier about don't mix manufacturers' materials. It's one system. And he would like to know, what is your opinion on using zirconia as an abutment directly on a titanium implants? Any science research on that in all the work you've done?
Well, there is some science out there I'm aware of. And unfortunately, really unfortunately, I do have some clinical experience on fractured zirconia abutments on titanium implants. There are several studies from Irina Seiler's group showing that you are better off, definitely better off, when you have a titanium insert where the zirconia material is bonded to. I'm wondering where this question is coming up because that evidence that was created by this group is quite strong and clearly shows that the addition of a titanium component leads to a much greater strength and you have less problems other than creating the quite complicated implant abutment interface from zirconia ceramic. But I know and I'm aware of a novel implant system where again, not just zirconia, but also different kinds of resins are directly seeded on titanium implants. I do not have experience on that. Maybe this is a newer system and works much better. I don't know. When we use zirconia abutments on our patients, there is always a titanium bias inside. Mm-hmm. I try to, have the implant abutment interface manufactured by the implant manufacturer.
Yeah, so you say at first sight, it seems simpler to just stay within one material, but maybe there is some innovation around the corner coming there, something to keep an eye on. Yeah, clear. Question from Saudi Arabia. This is a name, unfortunately, I cannot pronounce as I do not rate the script. And it's a very general and broad question. I'm not sure if this is answerable, but let's try. Is it better to do 2 single crowns or 1-piece bridge? I can imagine first answer is depends on the case, but is there anything to say about that? Any guidance?
Yes, at the first answer would be yes, it depends on the case. When you have a situation where you can either place 2 crowns next to each other and there is enough bone to do this, we would go for that. If there is more bone in an area where we would say, we end up now with a bridge, I would go for the bridge in order to avoid the bone augmentation. This is how a prosthodontist tries to think. I do not see a major difference between the long-term performance of 2 single crowns versus a 3-unit bridge with the implants positioned at the borders of that bridge. So exactly. We're not talking about the cantilever bridge, but we are talking about these final stage bridges supported on the mesial and supported on the distal side. Then I would not see a difference between 2 single crowns and that 3-unit bridge, for instance.
No. And is there then, we talked about that a little when we talked about the single supported edentulous patient, is there then an economical decision for either of the 2, or that doesn't matter much either?
No, I do not see that. I do not see that.
Exactly. No. Exactly. Clear. Let me give you another one. Peter van Elzas. It says, can you elaborate on the choice for screw retained multi-unit versus cement retained from the perspective of passive fit or the lack of fit? Arguments for cementation or to compensate for lack of passive fit? Can you take us into that topic a bit?
I hate cement. I hate it.
Why? Help us understand why.
It's a nightmare to clean that out. It's simply a nightmare.
So just simply from the clinical situation.
Yes. And I honestly, yes, we cement crowns in some instances, especially in the former times when we did not have angulated screw channels. I don't want to see on how many patients I have left cement remnants there. Passivity of fit of cement retained versus screw retained. Yes, in the beginning, many years ago, we also believed that the cement layer would kind of compensate for these transfer inaccuracies. It does not do this, definitely not do this if you are not able to achieve passivity of fit. In a screw retained restoration, you will not achieve passivity of fit in a cement retained restoration. So please.
And just to be very clear, these are outcomes from your scientific research also.
Yes.
That's why you say it so clearly. Yes.
But I don't want to bother you with the exact numbers. But
no, that's fine.
Feel free to contact me anytime. Yeah, definitely.
Yeah.
No, I'm very serious about this. Go for screw retained whenever possible. Whenever possible. I remember one day when I had to cut off maxillary restoration cemented on 6 dental implants, and this was made from non-noble alloy. This was a nightmare. I still remember the patient's name, and I still remember my situation and the situation of my assistant. Never again. Trust me, never again.
Well, Peter, you hit on a very good point here and a very clear do, or in this case, don't in implant prosthodontics. So thank you
screw retained. Do screw retained.
Do screw retained. I'm just going to take the liberty to run a little bit over time and take a few more questions because our audience is really getting heated up. Dr. AT says, would you place a smaller diameter implant to avoid having stability from the cortical bone? That is something you just referred to when we were talking about the case with Laura about the immediate implants. You said what you do is you create primary stability from the cortical bone, but that then resorbs. Would you then prefer a smaller diameter implant?
I do not necessarily see how this really relates to the implant diameter, because the stress that you generate during the insertion process of an implant always depends on the drill protocol that you have applied. And there are, of course, different drill protocols for reduced diameter implants and regular diameter implants. Frankly, and I could also show you cases on this, and when we're talking about materials, I know that the industry is always keen on showing that we have a superior material, and with our implants we can be small and narrow and short and whatsoever, and you can load it like a rock. I can show you pictures where these implants have been used for everything, and everything in Germany means telescopic crown and a huge cantilever, and within 1 year that implant fractures. So please stay within the cleared indications of these implants and abutment systems. Otherwise, you will have mechanical failure. Very simple. Yes, we do reduce diameter implants. I'm always not happy because even when you look at a regular diameter implant and you take away the amount of space and diameter that you need for the abutment connection, then you end up with very thin walls. And it's always every day again a miracle for me that these implants last so long and we see so few technical complications.
Exactly. Very clear. I'm looking at the clock. Let's start to wrap up, but not before we do a few more things. Stay tuned because I have an important announcement to make in a minute. But first to you, Matthias, if people walk away back into the clinic tomorrow, what are the top 3 things that you hope they take away from this session tonight?
First, ask why. Why have you lost your teeth?
Do I really understand why this patient is coming into the clinic today?
Yes, and what can the patient do? If the patient was not able to clean natural teeth, he or she will also have a hard time cleaning your implants. Second, implants are not for everybody from the treatment perspective, but also from the patient perspective. And third is remember dental school. Remember dental school and remember those days when you were sitting in a lab and we all did this and you were creating your own first crown and you got some advice on what this crown should look like. And remember that when you next time insert any restoration on top of a dental implant.
Exactly. Well, very strong messages. Thank you very much for your sharing your knowledge tonight, your very clear advice on the do's and the don'ts, and also for collecting that slightly painful failure festival from real cases that you come across in the clinic. It has been a very lively session tonight. Thank you to all our live audience members tonight. I can imagine that you would like this group to further gather, not only online, but perhaps also physical. I hope you have already saved the date, September 29 to October 1st, 2022. We're all going to meet up in Geneva for the EAO Congress. And if you haven't done so, please make sure that you register as soon as possible and be aware that there is a significant reduction in the registration fee for EAO members. So if you're not a member yet, this might also be the time to consider your membership. Early bird registrations last until June 15th, so that's coming up pretty soon. You have a little bit to decide, but I hope to see you there in person, or perhaps if you really can't make it to Geneva, somewhere online in the evenings where there might be some selection of some of the content that we have during the day, also in a digital format. More to follow on that. Matthias, thank you very much for sharing your knowledge tonight. It was a great pleasure and an honor to have you with us.
Thank you for having me.
Yes, and for those of you still watching, if you know anybody who might benefit from these do's and don'ts in implant prosthodontics, make sure you like this video, you share the link to as many possible members or members of your network that you know of. You can WhatsApp it, you can email it around, you can share it on your LinkedIn profile and show how you are educating yourself. And if you like this EAO Just Ask live sessions, make sure you hit the subscribe button on YouTube right now, so you'll be the first to know when the next live session is coming up. And if you cannot get enough, by now this is about the 25th EAO Just Ask that we have produced, so there's much more free knowledge from the EAO that you can go through and really educate yourself on the latest science in implant dentistry. Thank you all for watching and participating, and hope to see you next time.